Okay, thank you very much. Do you hear me? Yes. Ya niet говорю по-русски is the only thing I can say in Russian. I'm very sorry. I come from Spain, from Valencia, Spain, where we have beaches. Also, we have mountains like this one here, which I like to climb. We are going to talk about the mediastinum, and mainly we are going to concentrate on mediastinal masses. Now, imaging of the mediastinum, let me see. Imaging of the mediastinum can be done with different techniques, but mainly we usually and very often detect with chest radiographs, and then we will go into CT and MRI. But of course, we can use other techniques like PET-CT, which will show us, in many cases, additional information. Oh, let me go back, because I think biopsy is another thing we radiologists can do, but we have to be aware of the difficulties of biopsying the mediastinum. But of course, biopsy is important, especially in some masses like lymphoma, where biopsy may decide the treatment and are not surgical masses very often. In a simple way, we may say that in the mediastinum, the two main techniques we use are CT in the majority of cases and MRI, especially in posterior mediastinal lesions. This is one thing you should remember. Contrast uptake is important. Many mediastinal masses are very vascular and will have many vessels, like this thymoma. And contrast, either in a magnetic resonance or in CT, should be usually used when we study mediastinal masses. Look at these three patients. They have an unsuspected finding, which means that very often we will find lesions that are unsuspected. For some other reason, we have obtained a chest radiograph, and we have here one, here another, and here another. And these are three absolutely different lesions, and I will show you at the end what they are. The point is that very often we will find mediastinal masses and we were not looking for them. And this is what happened in this study of CT screening for lung cancer, where they found 0.77% of those patients, or of those people, which are not patients because this is a screening, where they found mediastinal lesions. And the thing is, the majority of mediastinal lesions we find are benign, 68%, and 32% are malignant. And of all these lesions, 25% are cystic, 17% are thymic, neurogenic, and so on. So when we look at the mediastinal mass, we have to use a technique. And what I propose is that we should look first at the clinical condition of the patient. Second, make sure the lesion is in the mediastinum. And in third, analyze the lesion. Now, we have here two patients that have a similar image or finding. This is a wide mediastinum here, and wide mediastinum. Now, this one is asymptomatic, and this one has myasthenia gravis. So the difference is that in this case, this is fat in the mediastinum that looks like a mass, but this is absolutely nothing, not important. In this case, this is a MRI of this area. This is hyperplasia, lymphoid hyperplasia of the thymus. And this lymphoid hyperplasia can be associated with myasthenia gravis. So the thing is that when the lesion we find is asymptomatic, the majority are normal. They may be variants, benign, or malignant. Now, when they are symptomatic, still the majority are normal, but variant, but malignant goes up a little bit. We have more chances that the lesion can be a malignant lesion. In fact, according to this author, 57% of the symptomatic lesions were malignant, while only 83% of the asymptomatic lesions were benign. Now, this is a kind of funny question. Why do we call it mediastinum? From the Greek, unknown region, from the Latin, middle, from the Spanish, meditation, or from French, remote? Well, actually, the proper answer is middle. Mediastinum means it's in the middle, in the center. But the mediastinum also is, as you can see, I like to climb some mountains. Another important thing is it's in the middle, but also it's a connection between areas, between the neck and the chest, and a connection between the abdomen and the chest. So this is very important to understand some of the lesions. Look at this case. This is a patient that has a lesion in the upper mediastinum that is displacing the trachea. And in the sagittal CT, we see that it's connecting with the neck. And this is mediastinal thyroid, okay? So this is one of the reasons why we have this type of lesions, because the mediastinum is a connection. It's connected. Look at these other two cases. This is, again, a patient that has a lesion here, and actually it's hydathic cyst, a canococcal cyst, growing from the liver and migrating into the mediastinum. Or this other patient that has this lesion here in the mediastinum that actually are varices because he has hypertension, portal hypertension, and varices, and they go into the mediastinum from the abdomen. So this concept of connection is very important. So the clinical condition we know is important, and we understand that the connection between the neck and the abdomen are important, and clinically that may be also relevant. Now, the second point is the lesion in the mediastinum. These are three cases, and which of these three the lesion is in the mediastinum? Anybody knows? This one, or this one? All of them, good. They could be all of them. That's correct, but they are not. This is our lymphoma I showed you before with PET-CT. This one is in the mediastinum. Where are the others? Look at this one. We thought we made a mistake. We thought it was in the mediastinum. This is a lesion that is very well defined. It's up here, and as we see in the CT, it's up here, and here, and the MRI. But this is a region that the lesion is too big, and then things are too tight. So although we thought it was a mediastinal lesion, actually this was a pleural lesion, because there is pleura also there. So we may make a mistake and confuse mediastinal with non-mediastinal lesions. This was a rare case of pleural schwannoma. And there are many pitfalls we may have. This one we thought also is one of our cases I show you that it was in the mediastinum, but actually this is a lung cancer next to the mediastinum, but it's not a mediastinal lesion. So main pitfalls are pulmonary lesions that look like mediastinal, normal mediastinal structures that look like a lesion, and pleural and chest wall lesions, like the one I show you with the pleural schwannoma. This is one normal finding that may look like a mediastinal lesion. This is a azygous lobe that is dense inside. And the density of this azygous lobe was described some years ago by my friend Jose Cáceres and a group from Barcelona. This is due to the superimposition of the vessels, of the long elongated vessels. And as you see in the CT, there's absolutely nothing. It's only this superimposition of these vessels over this in the chest radiograph that may mimic a mediastinal lesion. So to reveal, to find out or to decide if the lesion is mediastinal, we have to have a clinical correlation. We have to look for smooth borders, wide angles, and of course, displacement of mediastinal structures. And look at this case. We have to be good radiologists. We cannot diagnose only the big lesions. We have to look for small lesions and be bright when we work and shine like good radiologists. This is a patient that has had recently neck surgery. And in the chest radiograph, we see a little displacement of the trachea that is kind of away from the aortic knob. So there is something wrong going here. And if we look at the lateral film, which is very important, we see a density here that is too much. And when we obtain a CT, we see a lesion here, right here, with an air fluid level. And this patient had neck surgery recently. This is an abscess. This is a mediastinal abscess. And the subtle findings in the chest radiograph are the ones that oriented to the diagnosis. So you see this is the case before treatment and after treatment, which is this. You see that the density has disappeared. So you have to look for subtle findings. And look for the importance of the chest radiograph. Look at the PA film in this patient and look at the lateral film. And here in the lateral, we see an area that is very poorly seen in the PA film, which is the retrosternal area, and there is a density there that should not be there. And that's actually a thymoma. That's a mediastinal tumor. And again, as I showed you before, this case of varices, that is actually found in the PA film, where we see this displacement of a normal line. And the lines, you have to know very well the lines in mediastinum and the displacement of the lines. And they will reveal, for example, the peritracheal presence of adenopathy. Another good sign of mediastinal lesions is when you see what looks like a big heart, but the hilum is hiding behind the heart. This is the hilum overlay sign. That means that the hilum, if this was cardiomegaly, should be displaced outside. And it's not displaced outside because this is not in the heart. This is in front of the heart, in the mediastinum. And this is actually a large mediastinal cyst, thymic cyst. So, clinical condition, is it in the mediastinum? Okay, we advance, and then now we have to analyze the lesion. And the analysis of the lesion is very simple. We have to look at the location, the morphology, and the density. The location, according to several authors since many years ago, we have some typical lesions that are located in the different compartments of the mediastinum. In the anterior mediastinum, usually think of the 3 T's: thymic lesions, teratoma, and terrible lymphoma. And these are the most common. Of course, this is a fake T, but anyway, it works. And here you have examples of mediastinal lymphoma, and you have, again, another case of lymphoma, and you have a posterior mediastinal mass. And remember I told you that when we are looking at posterior masses, it's better to use magnetic resonance because you will look much better at the canal. And here, again, we have different examples of lesions: a thymic hyperplasia, a posterior mediastinal lesion connecting with the canal. This is a meningeal cyst, a thymoma, and another case of lymphoma. So the location is very important. We will see, in the workshop, we will see more about these things. What about density? The density is also very important, because it's different if we see water density like this, or we see calcium within the lesion, or we see contrast penetrating from the aorta, and that will change completely our diagnosis. So water, solid, fat, air, or contrast uptake are factors that will orient to the diagnosis of the lesion. Here's a case of thymoma that contains an area that is a little bit necrotic and calcium. A case of a teratoma, of a germinal lesion with fat and with calcium in the wall. And of course, the presence of air. This is not a case of a mass. This is air in the mediastinum. And we see this continuous diaphragm sign, which indicates the presence of pneumomediastinum. Of course, when we do a CT, it's very nice because we see all this air around the different mediastinal structures. This is a case of pneumomediastinum. But look at this case we had 2 weeks ago. This is a patient that came to the ER with a supposed diagnosis of pulmonary embolism. But we had this chest radiograph, and we see this density here. And when we look at the lateral film, and I told you the lateral film is very important, we see that this is a strange density because it's like a bulging here. And if we look more carefully at this area, we see this here. And this is air within the lesion. So what's air doing there? And what is this? The diagnosis is not so difficult now because we have seen the air. And of course, in the CT, we find that there's a large Morgani's hernia in front with some colon within it. So the presence of this density has oriented us to the diagnosis. So the steps in diagnosis mediastinal lesions is clinical correlation or condition, find out, make sure the lesion is in the mediastinum, and analyze the lesion. Now we have these 3 cases I show you, and the 3 of them are absolutely different one from the other. This is an aneurysm of the aorta, this is a thymoma, and this was a lung cancer I showed you before. So this is a proposal I make for the diagnosis of mediastinal lesions. We have 2 ways of entering a mediastinal lesion. One will be an incidental finding in chest radiograph, and then we have to evaluate what I told you. And should I proceed with CT or MRI? We have to decide, because maybe with the plain field, we are sure that we don't need a CT or MRI. In the majority of cases, we will go to CT or MRI. And then when we have a mediastinal lesion in CT or MRI, we have to look at location, cystic or solid, and other findings. Now, when the patient is symptomatic, then we directly will go, if the patient has, for example, myasthenia gravis, we will have to go directly into CT or MRI of the chest. And these are mainly the most important and simplified way to orient a mediastinal lesion. 3 references that I think are important for mediastinal masses. There are many more, but I think this can help you. And just to end up, show you the photograph of my friend Jose Cáceres, who couldn't be here because he had some problems, but Jose Cáceres has started last week a new blog in the ESR and my ESR page called the Cáceres Corner, and he is here with his Muppet. And if you enter my ESR in the blog, you will find he has 1 case already, and you can try to play with this case, and he will answer you, and he will go on and on. I expect for a long time. So with this, I finish my part of the mediastinum. Thank you very much.